Hello everyone, we are going to talk about the nerve injuries of the upper limb. We are going to start with the axillary nerve. It supplies the deltoid and the teres minor. Deltoid is responsible for the abduction of the arm and teres minor is responsible for the external rotation. Injury to it can result in patient's hand going into adduction and internal rotation position. Coming to the second, which is the musculocutaneous nerve. It supplies the biceps, coracobrachialis, and the brachialis. Injury to it can cause extension of the elbow, and forearm goes into pronation position as the biceps is responsible for supination. Coming to our next nerve, which is the median nerve. Median nerve supplies into the forearm and in the hand. In forearm, it supplies flexor group of muscles, majorly the lateral half of the flexor digitorum profundus and flexor pollicis longus, which is supplied by the anterior interosseous nerve, a branch of median nerve. Rest all muscles are supplied like flexor carpi radialis, palmaris longus, pronator quadratus, pronator teres, flexor digitorum profundus. In the hand, it supplies the thenar group of muscles except the adductor pollicis. So, pathology depends on the level of injury. If the level of injury is at the rest, the hand will go into an ape thumb deformity as the abduction of the thumb is lost. So, the patient will be unable to touch the pen if placed in a perpendicular plane, which is also known as the pen test positive. And if the injury is at a higher level, including the forearm as well, you will see a pointing index finger or Benedict sign positive when the patient tries to make the fist. Coming next to our ulnar nerve. Ulnar nerve supplies in the forearm and in the hand. In forearm, it supplies flexor carpi ulnaris and the median half of the flexor digitorum profundus. And in the hand, it supplies the adductor pollicis, lumbrical 3 and 4, and all the group of ventrosae. So, if the injury is involving the adductor pollicis muscle, it can be confirmed with the book test or also known as the Froment sign. And if the injury is at a higher level involving the whole ulnar nerve, the patient will present with partial claw hand. The fourth and fifth fingers, the metacarpophalangeal joint will go into extension and the PIP and DIP joint will go into flexion, known as the partial claw hand. And if both the radial and ulnar nerve are damaged, the patient will present with the complete claw hand. Coming to our final nerve, which is known as the radial nerve. Radial nerve supplies starting from the arm, the triceps muscle, later, in the lower third of the humerus, it pierces the lateral intermuscular septums and gives a branch to extensor carpi radialis longus. Remember this muscle. Then later, it further divides into posterior interosseous nerve and a sensory branch of nerve, which supplies the rest, the superficial and the deep extensors of the arm. So, if the injury is in the high end radial nerve injury, the patient will be unable to extend this arm even at the elbow joint. If the injury is before giving its branch and piercing the lateral intermuscular septum, it will result into wrist drop, finger drop, thumb drop, plus the sensory loss, as supply to ECRL is also damaged. And when the damage is beyond the ECRL, only the posterior interosseous nerve is damaged, you will only find the thumb and the finger drop. Remember, so with this, the radial nerve injury is also completed. Just remember one thing, beyond ECRL, there will be no wrist drop, but proximal to ECRL supply, there will be wrist drop. So this ends our topic of upper limb injuries. I hope you liked the video. Thank you for watching. Please give your valuable feedback in the comment section below.